So we had a discussion of MRI after cardiac arrest, anoxic ischemic brain injury. We talked about the MRI in septic shock, and now I will talk a little bit about the use of MRI to understand the patients with traumatic brain injury. So when we talk about traumatic brain injury, and this is an area that I'm particularly interested in, there's a number of uncertainties. In fact, I think we know much less than we think we know about TBI. One of them, the fundamental questions that we have is, what is the severity and distribution of damage that occurs in TBI? And I must say that clinical examination and even CT scan does not always answer that question. We don't really know which treatments are effective. In fact, to this day, we don't have a single therapy that is in fact effective in treating specifically the axonal damage that occurs in TBI. We don't know which individuals are more likely to respond to treatment or to intervention compared to those who will not. We know so little about how the brain adapts and repairs itself after TBI. We are even not so good at defining and characterizing long-term outcomes. And perhaps most importantly, we don't know why the outcomes after TBI are so variable, even given very similar initial clinical and radiological characteristics. We often observe outcomes that are dramatically different, and we don't really know why. So a lot of uncertainty. And perhaps the MRI that I'm going to be talking about is one way of reducing this uncertainty and potentially increasing our knowledge about this very important condition. Remember that MRI is multi-parametric by nature, so it gives us a huge amount of information. It tells us not only about the anatomy of the brain, it tells us not only about the physiology of the brain, the blood flow, it also tells us something about how the neurons are being activated. So it tells us something about functional activation. And this is what makes it such a fascinating tool. When we think about the natural history, the time course of changes that occur after TBI, we know that there is this so-called primary damage, primary injury, which consists in, for example, diffuse axonal injury. It consists in hematomas with compression of the underlying parenchyma. It consists in several contusions. So this primary injury is something which, of course, can be very well characterized using imaging, principally, at least with respect to contusions and extra-axial hematomas. CT scan is the modality of choice. Now, with respect to the diffuse axonal injury, it's very likely that CT scan is not sensitive or specific enough, and here is where the MRI is becoming increasingly recognized as the diagnostic test of choice. When we move on to the secondary phase after TBI and we think about this cascade of biochemical alterations that occurs, here again, MRI can be exceedingly helpful when we think about techniques such as magnetic resonance spectroscopy, when we think about methodologies such as cerebral blood flow imaging using MRI. These are very, very powerful ways to assess the physiology of the brain and understand the secondary injury that is occurring. And finally, when we are reasoning in terms of the long-term neuroplasticity changes and also long-term neurodegenerative changes that occur after trauma, here again, MRI is a very, very important tool because it allows us to look at changes in functional activation, and it also allows us to track the changes in volume, and especially the regionally selective changes in volume that occur after TBI. So this slide, I apologize, is a little bit complicated, but it tries to depict the types of changes that occur after TBI in terms of whether they are cellular, whether they involve the tissue as a whole, or whether they involve function. And the main point I'm trying to make here is that all of these changes that occur, whether they are cellular, going from axonal injury to synaptic dysfunction, cell death, and then this synaptogenesis and neurogenesis, whether we're talking about tissue changes, white matter damage, gliosis, atrophy, remodeling, whether we're talking about important modifications in function, all of these very dramatic changes that occur after trauma can be in some way or other identified, characterized, quantified, tracked using MRI. So this is a few slides about anatomy, and here you have this fluid, the flare sequence, which is essentially like a T2 sequence with the signal in the CSF that is nulled. And you can see that using this sequence in this particular individual after TBI, significant damage involving both the genu and the splenium of the corpus callosum. This same individual underwent a gradient recalled echo, and this is a sequence that is very sensitive to hemoglobin breakdown products. And you can see that in the same region where you have this flare hyperintense signal, you can also identify a hypo signal on gradient echo, and this suggests that there has been focal hemorrhage. In many cases, lesions of this type will be either not seen or very poorly identified using CT scan. Here you have a comparison of CT scan, gradient recalled echo, remember this is for identifying hemorrhage, and susceptibility weighted imaging, which is a little bit like gradient recalled echo, but much more sensitive in terms of identifying hemorrhage, perhaps too sensitive. And you can see that whereas CT scan did not show any significant abnormality, using this SWI technique, you can see multiple foci of microhemorrhage, and these hemorrhages are the burden of hemorrhage, of microhemorrhage, and many people believe that this represents a hemorrhagic variant of diffuse axonal injury, is actually very important. This is a study in children showing that there is a relationship between the Glasgow Coma Scale on admission and the mean number of lesions or the total volume of lesions identified using SWI. And here you can see that when outcomes were assessed at 6 months, there was also a very, very distinct correlation between, again, the burden of hemorrhagic injury using this particular MRI technique and the long-term functional outcome. And what about diffusion-weighted imaging? We talked a little bit about diffusion-weighted imaging in the prior talk on anoxia. And here you can see this is an individual who had a traumatic brain injury. You can see that on T2. You perhaps begin to identify a hyperintense signal here in the splenium of the corpus callosum, but it's much more apparent using this ADC. And here you have a hypo signal. This suggests that there is cytotoxic edema and indicates that there has been a significant lesion in the corpus callosum, a very characteristic location for diffuse axonal injury. We talked also in my last talk about the use of diffusion tensor imaging to try to understand the microarchitecture of these white matter tracts in the brain and also in the brainstem and the spinal cord. And many people believe that this is a technique that is very, very suitable for assessing TBI because of the preponderance of axonal damage in TBI and the possibility that diffusion tensor imaging allows us to identify that damage. So you're all familiar with the pathophysiology of traumatic axonal injury, which has many, many different steps, but which is principally involving a dysfunction of the membrane with changes in ionic fluxes and local swelling. These focal bulbs that occur in the axons are very characteristic, which are then subsequently associated with cytoskeletal damage and ultimately lead to disruption of the axon. So this traumatic axonal injury, which is thought to be a constant feature in TBI of all severities, is exquisitely amenable to identification using diffusion tensor imaging MRI. You might ask, well, is there any direct correlation? Have we been able to determine whether what we are seeing using DTI actually correlates with histological changes? And in fact, there are data to support that. This is a paper from Dr. McDonald and Dr. Brody from WashU, where they, in a rat model of TBI, were able to show a direct relationship between histological evidence of traumatic axonal injury and diffusion tensor imaging evidence of white matter damage. So a very important study. I showed you earlier this slide, which is not a quantitative image, but more a qualitative image of the degree of the magnitude of white matter loss that can occur after TBI. And you can see this dramatic loss of white matter tracts that is diffuse and even involves the brainstem in this individual after TBI. What is remarkable is that when you look at the conventional MRI sequence. This is a T1 sequence, or it's a flare sequence actually. You can see that the extent of damage is not at all as apparent as when you use this tractogram here, looking at specifically the white matter tracts. So is there any relationship between TBI and outcomes? This is a very, very interesting study looking at FA values. So fractional anisotropy is a quantitative variable that tells us something about the degree of damage of white matter tracts. And you can see that when you compare controls with mild versus moderate and severe TBI subjects, you can see that across different brain regions, the FA values are significantly lower in those individuals with moderate and severe versus mild TBI. And when you look at the relationship between FA values and performance on a number of different cognitive tasks, executive function, attention, memory, and this was done 1 year after TBI, you can see that there is a relationship. So the occurrence of this multifocal white matter injury is indeed predictive of performance on cognitive testing in the long term after TBI. This is a seminal paper from Sideros in Scandinavia, looking at the relationship between fractional anisotropy measured in the acute setting in the first 8 weeks after TBI. And this was measured in selected structures, the posterior portion of the corpus callosum, the cerebral peduncles, the centrum semiovale, the posterior limb of the internal capsule. And you can see that there was a relationship. So those patients who had a favorable outcome tended to have a higher FA value acutely compared to those who had an unfavorable outcome, and this was measured using the Glasgow Outcome Scale. These are data, again, coming from my collaborator, Dr. Pibasset and his team in Paris. And here again, when they compared in 100 individuals with severe TBI who were evaluated at 1 year, when they compared those who had unfavorable outcome versus those who had favorable outcome, there was a significant reduction in FA values across almost every single brain region, every single one of these 20 brain regions that was analyzed. When these same investigators performed a receiver operating characteristic analysis, they found that the use of DTI, when incorporated into a multivariate model that included the impact, which I'm sure you're all familiar with, which is a outcome prediction score for severe TBI subjects. So when they added the DTI to the impact, they found that the area under the curve was significantly increased from about 0.6 to close to 0.9. So a very, very dramatic improvement in predictive ability that was offered by integrating this imaging parameter into a scoring system that has basically clinical and CT characteristics. This is a paper from Virginia Newcomb, who is in David Menon's group in Cambridge. You can see that these changes of white matter that are identified using MRI occur not only acutely but are long-lasting. Here you can see, if you just concentrate on this part of the slide, FA values, and here you have controls, good recovery, mild disability, severe disability, and vegetative state. You can see that FA values are significantly lower in vegetative patients and those with severe disability when compared to controls or when those who had a good recovery. So you can see that there is a relationship between this white matter damage across different regions. So here we have, for example, the subcortical white matter, anterior corpus callosum, posterior corpus callosum. Across regions, there seems to be a relationship between white matter damage, both acutely and in the long term, and poor outcomes. What about the volume of the brain? It's one of the most remarkable things about TBI, especially severe TBI, is that individuals tend to lose brain volume over time. So if you sustain a severe TBI, even though you may regain function, you may wake up. If you get repeat CAT scans or repeat MRIs over time, it'll be observed that the volume of your brain will decrease in a manner that is not consistent with just aging. There's an accelerated process of atrophy that occurs in TBI survivors. And here you have some very nice studies. This is using voxel-based morphometry, which is an automated methodology to look at brain volume changes. You can see that there are significant changes occurring in many different regions, and that the amount of, not surprisingly, the amount of brain volume loss was correlated with functional outcomes. And this is another paper demonstrating essentially the same. This is a paper from my colleague Paul Vespa, which is, I think, a very, very interesting study because it kind of relates measurements that can be made acutely in the ICU, using some of the neuromonitoring techniques that we've been discussing here at this meeting, and long-term changes in brain volume. So here you can see on the x-axis the degree of, or the percentage of atrophy occurring in these different lobes: temporal lobe, frontal lobe, parietal lobe. And here you can see the parameters that were measured acutely in the setting of TBI. So here's the brain metabolic rate of oxygen, cerebral blood flow, brain glucose uptake. And you can see that the magnitude of atrophy observed in the long term seem to correlate at least with decrements in metabolic rate of oxygen, with decrements in CBF, and decrements in uptake of glucose. So a very, very interesting observation that this metabolic dysfunction that occurs, or these physiological changes that occur in the acute setting, do potentially have an impact on the long-term structural integrity of the brain. There is a relationship there, which is exceedingly interesting, and I'm hats off to Dr. Vespa for this very important study. And finally, to talk a little bit about metabolic changes, this is a slide looking at spectroscopy, which is a method that allows us to measure regional concentrations of metabolites in the brain. This is an MRI-based methodology. And we can measure different metabolites, such as, for example, N-acetyl aspartate, creatinine, choline. N-acetyl aspartate is thought in many ways to reflect the integrity of axons. And when you see a drop in the relationship between NAA and creatinine, as occurs here 3 days after TBI, this relationship has collapsed, and this is an indication of severe axonal dysfunction or even loss. Here you can see 7 months later that some of this proportionality between NAA and creatinine has been restored, but not completely. So a very, very interesting methodology to assess function, metabolic function after TBI. This is a group of individuals with mild TBI, concussions, and you can see that when you look again at this NAA to creatinine ratio after a concussion, which most of us would agree or identify as a mild type of brain injury, you can see that there is this very dramatic drop in NAA to creatinine ratio, and that the return to normal does not occur in a few hours or in a few days. It takes actually up to a month and maybe even longer for this metabolic dysfunction induced by a concussion, again, to return to normal. And maybe this is what accounts for some of the long-term sequelae that we observe in many concussion victims. Moving on, there have been some very interesting recent observations on the combinations of different imaging techniques. So here, for example, you have a combination of diffusion tensor imaging looking at white matter tract integrity, and magnetic resonance spectroscopy looking at regional neurometabolite concentrations. And you can see that both of these measurements, both the DTI, which was here the fractional anisotropy, and also the NAA to creatinine ratio, were indeed predictive of one-year outcomes. And when they were combined together in using a linear discriminant analysis, these authors found that they were able to get extremely good discrimination between patients with good and poor outcome. And finally, to talk a little bit about functional MRI, I think, to say very briefly, the functional MRI is only in its infancy in terms of assessing the sequela of traumatic brain injury. This is a very interesting recent paper from David Menon and his group looking at the functional activation that occurs with a simple motor task. And you can see here a healthy control with activation of the primary motor cortex, activation of the premotor cortex, activation of the cerebellum, and here is another paper looking at working memory after TBI, and you can see that when you compare it with controls, you can see that there is a loss of efficiency. The amount of cortical resources that need to be recruited to perform a simple memory task in TBI subjects was significantly greater than in controls. So, and finally, regarding this issue of looking at the connections between the different parts of the brain, you remember that we insisted upon the importance of white matter damage. Well, what is the functional correlate of this white matter damage that is so frequent in TBI? This is a very, very interesting study by my colleague, Ramon Diaz-Arrastia from Texas, where he looked at the time course of the bold signal in the hippocampus. So the right is red, the left is blue. And if you look over time at this bold signal, you can see that there is this fluctuation. And this is in a control subject. You can see that the fluctuation between right and left is more or less coherent. And here is a subject with TBI, and you can see that there is a loss of that coherence. So the fluctuations no longer are mirroring each other, and you get a form of disconnection, probably due to the damage occurring, again, within the interhemispheric fibers in the corpus callosum. And when they looked at this index of interhippocampal connectivity, they found that it was correlating quite nicely with a short-term memory task. So a very, very interesting initial observation. This is data from our group, and we looked in a small number of subjects with severe TBI. When we looked at connectivity within a motor network, we found that loss of connectivity was a significant predictor of poor outcome. When we looked at connectivity within the left frontoparietal network, which is an awareness network, we also found that those subjects who did poorly at 1 year had a reduction in connectivity. So to summarize, I think we can say that white matter damage is really a fundamental aspect in TBI. MRI is exquisitely sensitive to white matter injury and can help to prognosticate after TBI. We know that there are changes in functional activation after TBI, that they are common and that they are diverse. And we also need to do more studies using MRI to enhance our understanding of post-TBI repair and neuroplasticity. So thank you very much.
Thank you.